student workshop of the year, and the workshop is entitled "Working as an Indigenous Health Professional in an Indigenous Community." I think everyone knows me on the call, but for the sake of the recording, my name is Dr. Kent Saylor, Mohawk Nation and pediatrician. I'm the director of the Indigenous Health Professions program at McGill University. And we're very privileged to have 3 speakers. We have 2 on with us right now, and hopefully the third will join us a little bit down the road. She may be busy at the moment. And they're going to share some of their experiences with you about their experience so far working as an Indigenous health professional in a community. I tried to get a good mixture of people. So we have some people who've been doing it a very long time, others who are a little bit newer to it. I tried to actually get one of the nursing staff from the Chisasibi hospital. She agreed, but unfortunately she had to cancel on us. So we have 2 physicians and 1 social worker. And I think we're going to go ahead and get started. I will ask everyone to remain, for the most part, on mute unless they are speaking. And you can feel free to leave your video on if you like. You can feel free to close it, whatever works best for you. And I will be acting as moderator. So any questions that you have, we could do one of 2 things. Probably the best thing is to put them into the chat. And then I will do my best to bring those questions up towards the end. I think what we'll do is we'll have everyone do their presentation, and then at the end we'll go through some questions. Yeah, so just put them in the chat. And if we want to have some discussion at the end as well, we can kind of play it by ear and go from there. So I will ask first, I'm choosing Elaine just since you're first on my screen in front of me. I will ask Dr. Elaine Kilabuk to go first. So Elaine is a graduate of McGill University Medical School. She is an Inuk woman who I think spent quite a bit of time as a youth in Nunavut, then some time in the US, and then made her way back to Canada. And she has just recently finished her internal medicine residency and fellowship at the University of Ottawa, and is working as an internal medicine physician in Nunavut. I think, Elaine, primarily in Iqaluit, right?
Yes, exactly, in Iqaluit.
So perfect. Elaine, go ahead.
Awesome. Okay, so thank you, Dr. Saylor, for inviting me to talk today. So as Dr. Saylor said, I'm originally from Pangerton, Nunavut, and we moved away to the States, so I mostly grew up there, but all my family and my dad were still up north, so we go back up and visit. And as he mentioned, I just finished internal medicine fellowship, and so I'm working part-time in Iqaluit and then part-time in Ottawa as well. And then so I'll share my slides. There's just 3 slides that I wanted to share. See if I can figure out how to do this really quickly. And it was more just for people who might not be familiar with Nunavut in the sense of how it's kind of broken up, which obviously be very different than Nunavik. Sorry, let me just do the slideshow. No, it's not working. Anyways, okay, so Iqaluit is the capital of Nunavut, and then so there's 3 different regions that we have. So, and they're shown by the different colors here. So there's the Iqaluit region, there's the Qikiqtaalmiut region, and the Kahnawake region. And so you can see how the small little communities each has its own kind of hub, I would say. So if there's any issues in that community and they have to be flown down, so it's Edmonton, Winnipeg, and Ottawa, sometimes Montreal, but mostly Ottawa. So as you can imagine, say from a more northern community, in terms of flights down, they'd have to go first through to Iqaluit and then down to Ottawa over here. It's just people who aren't aware of kind of the 3 different regions and how it works. So this is Pangerton. This is actually a picture from the house that I used to live in, very close to Iqaluit National Park. And then this is Iqaluit. And there's the hospital right there too. So, and then I'll talk about, I'll stop sharing. There we go. There we go. Okay, so I think, so as you mentioned, I spend half of my time in Iqaluit and half of my time in Ottawa. And I'm very, I'm very early in the starts of my career. So I'm very excited to actually hear from the other physicians in terms of, who've had much more experience throughout their practices and hearing the positives and negatives for them. And I'm sure as time goes on, my opinions and feelings will change. Obviously, the more that I practice. So in terms of some of the talking points that I wanted to bring up, so for the positives and negatives of aspects of working in Iqaluit, I would say one of the big, or lots of the big positives, so it's a unique and empowering position to be an Inuit physician and then working and providing care to Inuit people. That in itself, I think, gives me a sense of pride, and I feel a sense of appreciation from patients as well. And it doesn't go unnoticed, and it's amazing when people come up to me and say how proud they are of me being an Inuit physician and working in the community and providing that care for them. You would definitely have a sense of community within the hospital itself, and then amongst the people themselves. It's very easy to find patients, especially if it's in a smaller community. You can probably just radio to ask where someone might be, which is really nice. And then obviously when it's smaller, in terms of, say, if you wanted an urgent lab or an urgent CT, anything like that, you can actually just walk over to lab or pick up the phone, and it's very easy that way. And then I think I would say something that I have to get used to because of the fact that I go in and out is recognizing and balancing and remembering the culture sensitivity and appropriation, even for myself, that for my own personal experience. I have trained mostly, obviously, in large centers, and the fact that I've mostly lived in large cities. And so even with that, in terms of the pace and the environment is very different, and I have to be very cognizant of that and remember that I would say on a daily basis, just because it's different than, say, obviously what might be different in Ottawa or Montreal or places like that. And I think, any environment that you work in is always going to have their positives and negatives. And I think especially early on working in an Indigenous community, for me, it's picking, I would say picking, what I guess negatives that you would want to discuss, and then explore in the sense of how you can make it better, or can you do anything to make it better. And obviously not choosing too many because you don't want to place yourself in a negative light where all you can see is the negative in the care that you're giving. I think that, so some issues in terms of working in, so it's not my own communities. Like I said, I'm originally from Pangarton, but a lot of my family has moved to Iqaluit. And so I think I would say some issues in terms of working with that obviously is going to be so family members or people who might know you. And then part of that is also being any family members coming up, or even if you see them when you're hanging out, asking medical information specifically and pertaining to them. And at least for me, it's just speaking in generalities about the topic rather than direct advice to them, since they're not my patients. But that's something I feel like that definitely happens more often. And then I think something I've always appreciated is when this is always a positive too, in the sense of the community sense that you feel, is that with a lot of my patients, since they know that I'm from Pangarton, they'll always ask like which family of Kilabuks I'm from. So then I just name all of my aunts, uncles, cousins until they know, until they know which Kilabuk family I'm from. And then, like I said, you get kind of that instant sense of knowing someone, or because you know their family in some way or another. So I think that's a nice positive, I would say, of working in the community is that aspect as well. And then again, goes along with the same thing of family members. So I personally don't provide care for family members. Sometimes I do know patients or they know of me, but obviously it's keeping it as professional as possible. And then I think the biggest thing is when you are seeing them out in a public setting, even if they're trying to disclose information to you, being very upfront and saying that just to call or make an appointment or things like that, just so you don't have any of that information out in the public, especially for patient confidentiality. I think obviously an issue, in most communities is not going to be something specific to Iqaluit or Nunavut, is going to be dealing with limited resources. I think that's an adjustment that I am and will struggle with going forward, just because, working in two very different settings. So Ottawa being where resources and specialists are so available, and then in Iqaluit where it's less so, and specifically say for internal medicine, when I'm there, I'm the only internist in Iqaluit for that region, versus Ottawa, there's hundreds of us. And then even with that, in the sense of specialists, how that might not be at your disposal as it would be in a big city. And I think something for myself, even, when I was planning out my clinic there and my practice there, it was really a personal reflection and decision and process making of deciding what I was going to be comfortable with from a medicine perspective, and what I'm not comfortable with. And that's something where I set out early on and say, I won't see these types of patients, you'll still have to refer them out. But that took a lot of reflection beforehand to be able to do that. And then even when I think about limited resources in the sense of, say, labs or specialists. So from a lab perspective, I think, so at least the way it works in Iqaluit, we do have majority of the same labs that we would in Ottawa. It just might take time. It might take a week or two for a thing, because they have to be sent down. And then obviously it might take longer if they're from a community, and then it has to go to Iqaluit and then Ottawa. But I think for myself, and obviously I'm very early and fresh on in my career, that it might take more time, but personally in my mind, if this was available to me in Ottawa so readily, I think I have the same mindset of why would I change it differently? It might just take longer. But I think the biggest thing is not making me feeling like the limited resources is going to jeopardize the care for the patients. Obviously, there'll be a balance of that as time goes forward and I get more comfortable in my practice. But I think for right now, just being very open and being okay with the fact of I might reorder things or order things that might take a while. But if I would do it in Ottawa, then why not do it there either? And then I think a big thing too is that as time goes on, I've realized having resources of other people, so either other internists or even specialists in the community in Ottawa. So I have to say, being able to reach out to, if you have a group of other physicians from other specialists is very helpful, especially if you're going to be the only one in your community. It's easier to reach out to them for advice or to ask questions via email, just to run things by other people. I think that's really helpful. And then even on the other side of, in terms of the limited resources aspect, trying to make it as easy as possible for patients. If you can. So for example, I've had a few patients who are going to come down to Ottawa for another reason, and I needed them to see another specialist. So I reached out to that specialist to ask if they could be seen in an appointment, because they'll be down there for a certain period of time. Same thing for imaging, in terms of I had a patient who needed an echo non-urgently, but the wait time sometimes can be up to 2 years in Iqaluit. So if she's going down for surgery, I can try and get her an echo when she's in Ottawa, because the wait time is shorter. So things like that, where I feel like, you are obviously dealing with limited resource within the area, but if it can make it any easier for the patients to, I would say, improve their care or make it more feasible, try to do that too. At least that's what I've done. And then I think from, even thinking about how I was trying to plan my practice and what I wanted to bring, it all, at least when I even thought about my training in fellowship, it was about, that aspect of what can I bring? Obviously not just being a specialist, but what can I bring in terms of kind of procedures or So say, for example, exercise trust test, that's something where I did more training in. So that's something I could bring up to be able to read them, and we can get a clinic set up for that. Same thing for echo, same thing for perioperative clinics and high-risk pregnancy. These are things where I identified things that I was interested in, and that was something that might have been, limited access to or delayed access to. So those were things I did early on to be able to identify those, and then get more training in my fellowship to hopefully, again, bring that up to the community. Obviously, with getting things set up, part of it is also want to get things set up in a successful way where it's not actually just reliant on one person, because I do think that can be a setup for failure as well. Because if for whatever reason, life changes and you don't go to the community more, then everything just completely drops. So that in itself, I think, is an important thing to have in mind when setting up kind of new things or what you can bring to the community. I would say, I guess I'll talk the last point. So I'm probably going past my 15-20 minutes, but I think it's living in the community versus traveling the community. And like I said, I'm interested to hear other people's perspective, just because like I said, I go back and forth into the community. So I think there's definitely sometimes aspects of feeling like an outsider in that sense, where I am Inuit and I am from Nunavut. It's just that the idea of that I don't live there can sometimes make me feel like an outsider. I think with that, part of it is obviously not being too critical of the environment and structural issues, especially early on. Obviously, you don't want to burn bridges and make it seem like the environment and the care is negative. And then I think even the small things is something that I've realized is just as important. So say even for examples of, saying that you're excited to leave to somebody else, how that in itself can be, it's a small thing, but it's obviously a reminder to yourself and to whoever who's lived there that you're not from that community. So even, being conscious of those things. And I think for me, that's something where for someone who goes in and out, just trying to be conscious of never making anybody, either the nurses or the patients, feel like it's not that I don't want to be there, it's not that I don't want to live there full time, it's just that within my own personal and family reasons, I can't right now. So I never want to make someone feel less than that. So I guess I'll stop there on that note. My kind of personal, experiences and thoughts about, of working in Iqaluit and in Ottawa.
Thank you, Elaine. Actually, it was very interesting, and I liked your last point about when you're leaving. It's I actually never thought of that, so very interesting. Great. So we'll have some time for questions and discussion at the end with Dr. Kilabuk. And next, I'd like to introduce Mike Loft, who is a social worker, now retired, but I feel like I see him more now than I did before. Mike, he is a member of the Mohawk Nation from Kahnawake, and he worked as a social worker for many years in Kahnawake, in youth protection system and in other areas. And then in, I think it was the late 2000s, started working at McGill as a professor in the School of Social Work at McGill, and did that for 10 years and retired a few years ago. And Mike is still very much involved in teaching for us with the Indigenous Health curriculum at the medical school. So Mike, I will turn things over to you.
Mike, I believe you're muted.
Yeah, we can't hear you, Mike. It does say you're muted still. I don't know, Sadaf, can you unmute him?
Mike, you are unmuted as far as I can see, but it might be your microphone that isn't working. Mhm.
I'm okay now?
Yes.
Yes.
Okay, okay. Sorry about that. We always struggle, me and Dr. Saylor, with this technology. I do anyway. Today I want to talk about the social work client relationship, doctor patient relationship. You know, that relationship, that thing that goes on between two people. Over the years, we've heard a lot about the social determinants of health, the impacts of poverty, housing problems, all of these things that beset the Native people. But today, I want to focus more on what I call the interpersonal determinants of health. Okay, I don't know if anybody's ever used that term. And specifically, the small unit of the doctor, patient, social worker, client type of situation. Okay, that's what I'm talking about today. That's what I want to present about today. I'm a big believer, and excuse me, I have to refer to my notes to make sure I get this down right. I really do believe that when we're dealing with clients, when we're dealing with patients, we have to do our best to develop truly human relationships with them. Okay. I don't even like the word client or patient. These are people. I try my best. I've always thought of the people that I have to deal with, you know, and in human terms. They're not just clients, because it has a way of, I think, separating us and distancing us. Okay. When we deal with clients in the Native world, Indigenous world, it helps when we try to study and try to become what they call culturally competent. Now, that's a big fancy buzzword, okay, that really stands for transferring your knowledge, you know, what you've studied about, particularly the Inuit people, the Mohawk people, whatever. I remember myself back in the day as a young social worker, I had to train, we had to do field placements all over Montreal. And one of the places I was sent to was Ville-Marie Southwest in Verdun. And I remember I had to deal with a sizable caseload of people who were recent immigrants from Greece, that type of thing. So the first thing I did was I hit the books and tried to study, who are these people? Because I'm from the res, you know, and I would never meet anybody from Greece here. So I studied, I prepared for that as a young student. I made that my business to try to learn, you know, to put that knowledge in as best as I could. What does the Greek family think? What are their thoughts about how families operate? Okay. Who do you approach when you address the family? Do you speak to the man first? Do you speak to the woman first? How do you present yourself when you're knocking at their door? Okay. I had to learn all that. So the first thing is to make sure you get the knowledge that you need. You do them a favor, and they can pick up on you when you've done a little bit of your homework. They respect that. I don't think they respect it when you come in there cold, you know, not knowing much about them. The other thing is having adequate skills, okay, to deal with them, and whatever you know is needed to help them with their problem, to quickly get to that part. And if you can help and you have the skills, help them to solve these. If not, refer them, you know. None of us know everything. So when we don't know something, you know, we have to make moves, and we don't waste their time. That makes them feel strong about themselves, you know. And again, it works on the principle of respect. When we respect our clients or patients, okay, they feel a lot better towards us. And the third one is our attitude. So it's about cultural competence is about knowledge, it's about skills, and it's about attitude. As I said earlier, I worked a bit up in, or I visited, okay, what we call Fort Chimo back in the day. And one of the things that I noticed, like Elaine, Dr. Elaine had mentioned earlier, was kind of like the shock effect when I first got up north. You know, this was back in the 70s when I was up there. And things were, there was a kind of like an us-them kind of like thing going on, you know, whether you were Inuit or whether you were a Southerner, that type of thing, which I picked up on very quickly. And what I had to do was I had to very quickly learn not to judge, you know, not to judge, okay? Things are different up there, okay? There's strong, there's beautiful things like the strengths of the family, the sense of community. There's different strengths up there that you have to note and see, okay, and acknowledge. But sometimes we just fixate on the negative, the drinking, the problems type of thing. So I think it's very, very important to bring the proper attitude with you. So it's about cultural competence is about the knowledge, skills, and attitude, okay, that we must bring. Because what this all does is it supports the whole notion of caring, okay, for people. When the people feel that you know, okay, something about them, you're telling them, you know, maybe subconsciously that you care. When you're having the skills and you're a skilled operator who knows how to deal with them and deal with, you know, their needs, medical needs, social needs, whatever, in a skilled fashion, they feel cared for, okay? And the same thing is with your attitude. If you're truly got their backs, these people, okay, they're gonna feel cared about. And these things are important because without these skills, okay, without the cultural competence, we literally can't understand others. We can't understand these people. And we're in trouble when we can't understand these people, okay? Because if we're just going to try to understand their disease, okay, or in social work parlance, the prise en charge, you know, whatever they're in trouble with and why a family or an individual is meeting you as a social worker, if that's all there is to it, you ain't gonna go far, okay? Stands to reason. So we have to do our best, okay, to make sure, okay, that we care for people based on our knowledge, skills, and attitude, because that's how we understand people. And that's what, to me, a lot of life is about. Without, you know, our capacity to build relationships, okay, in life, to build relationships with others, okay, we have practically nothing, okay? We have next to nothing in life. Life is about that. It's about those connections and building relationships, especially with our clients, okay, our patients. Because without it, we exist, okay? Without it, we exist with people we don't understand. And who wants to be involved with people like that? We don't truly understand. And then we fall prey when we're like that, not really knowing who we're dealing with, okay? We fall prey to biased, we fall prey to hurt feelings, and sometimes misunderstandings, sometimes tragic misunderstandings, okay? For me, it's all about relationship building, the one-on-one relationship that you have with your patient, your client, okay? To me, that is key. It's the same thing with when I used to have clients. Then later in my career, I had students. It was all about relationship building and trying to reach them at a different level, okay? So what do I mean by that? And this is the last part here. Recognizing that relationship is everything. It isn't about the prise en charge alone. It isn't about the disease alone. That's what I'm trying to say, or the psychological condition alone, or the psychiatric condition alone. It's so much more than that, okay? It's about that thing that's going on between you and that person, okay? And I'll tell you why. Because that thing that goes on between two people, okay, in that professional relationship is the catalyst to freeing energy to solving problems. That's what it is. It's the fuel, okay, that you need to build a fire, okay? You can't make if you know, if you have a good wood stove, I mean, you need fuel. If you need a car, you got a car, you need gas, if you know, you need electricity, whatever it is. But relationship building, okay, is that fuel, okay, to problem solving. It's how, okay, the relationship, and there's a difference, okay, there's two things to think about with this relationship, okay. There's the professional relationship and the so-called regular relationship that we have in life, okay. The so-called professional relationship is basically when you're attuned to how the relationship influences a person's motivation and behavior, okay? Because as a social worker, that's what you want to do. That's why you're with your client. You know, you're all we have social workers is our ability, you know, to work with relationship, to use our words, you know, to use, you know, our minds, our words, our emotions, everything, you know, to try to influence the person's behavior, to provide that fuel so that they can access resources, okay, and change their lives for the better. That's all it is. That's all it's about. And it's the same thing for you doctors too, because how many times, you know, we get frustrated, you know, with our patients, you know, who are given the knowledge from the doctor about diabetes, about getting some exercise, losing some weight, this and that and the other, and it's like it falls on deaf ears, and they continue to not listen. They continue to get sick, and you see that, okay. What can be done to impact that, okay? Perhaps looking at that interpersonal relationship, okay, a bit closer might bring us to the point where you can flip that client, or that patient, and that person begins to take charge and begins to do something about their lives in a positive way. It's like flipping a person. Then you have a true working relationship with your client, okay? Another point is, so the first point was, you know, how the relationship influences a person's motivation and behavior, okay? That is what it's about. The second point is how its power to help or hinder a person's use of services, okay, is also a factor, okay? Because if we're not doing it right, we may be bordering on not helping that person get better. It's as simple as that. Demotivating them perhaps in some cases, all right? So that's another factor in the so-called professional relationship, okay, that we have to look at and must be, you know, that's part of the toolkit. And lastly, on this part, it's how our own thoughts, you know, as clinicians, as social workers, doctors, psychologists, etc., how our own thoughts and feelings, okay, influence that relationship, and keeping kind of like, you know, abreast of yourself, keeping abreast of your own self and where you're at, okay, with yourself. Because sometimes we're overtired, sometimes we're tired of flying around all over, sleeping in hotels. We're tired of not having, like Dr. Elaine said, you know, maybe that close relationship in the community. We're sometimes feeling like we're outsiders. You know, we have to keep track, and we have to also be sure of where we're at and where are we coming from. Okay, we must take that into account, because as we know in psychology, when you think you're not transferring things, you are transferring. And I often say the clients are the smartest people around, because they can read us too. We're reading them, but they're reading us right back. I've learned that, you know. So it's very important to keep track on yourself. So that's the third point I want to make about how you can be attuned, okay, to your patient, your client, in a more professional way. Those are the ingredients, okay, that are involved in that. When we're not doing that, when we're not thinking about our patients and our clients to that degree, okay, when we're not, okay, well, it's kind of like a shame, okay, it is kind of a shame. Because when we're not tuned in, what we're really doing is we're just sort of like acting naturally, you know, the way we deal with anybody, probably in the street or for that matter. And when you're not acting, when you're just reacting like just naturally, like you would with anybody, you're not really reacting to your patient, to your client, to the degree that I had just expounded a bit on, okay? We fall prey, okay, to simply being turned on or turned off to people. I mean, this seems to be roughly the criteria, you know, for this other situation that we could fall into, okay, as professionals. It's when we're not attuned to the level that I just mentioned earlier. This is kind of like what happens when we're not, okay? We fall prey to that thinking and kind of like that black and white type of way about people. And I've seen that in my time. I've seen that. I've seen, you know, medical people. I've seen social workers, you know, who are exasperated, who are not in touch with their own feelings, making bad decisions about clients, all right? And this is where I'm a big believer in supervision. We all must have great supervisors who we can talk to and trust, who can help us with our own selves and our own personal feelings and thoughts as we're going through this process of dealing with people. Okay. Otherwise, we're lost. We really, and we have to, and it's not just, you know, a simple supervision where, you know, we're, you know, it's based on accountability, but to really, again, it all falls back to that thing, relationship, having that solid relationship with your supervisor who will give you the good feedback that you need when you're stuck, okay? When you really need some good advice, or you're struggling yourself, and somebody who will listen to you, okay, and help work you through whatever it is that is a problem for you, okay? So I will leave you at that. I hope that I impacted a little bit on our understanding of there is the social determinants of health. Yes, Lord knows there is. I'm one, I often tell people, I grew up in total poverty myself, and my dad was a residential school survivor. It was rough. It was rough, but got through it somehow. Got through it, and that's the main thing, you know. And when you're in that position, you often become very, very attuned, okay, to the way people treat you, because it seems like when you struggle from poverty and things like that, people treat you different, okay. So maybe this is one of the points, you know, that is personal for me, and but it's also been backed up, okay, in study after study, book after book. I'll throw one author's name. She's a social work professor. Back in the day, I read her book. Her name is Helen Harris Perlman, okay, and she writes about that, about the social work relationship and the relationship between human beings in general. It's a wonderful book, Helen Harris Perlman, and you know, like I said, interpersonal factors come into play. Okay, they come into play because I think a good doctor. Okay, I remember I had a good my high school principal. You know, used to be behind me. He had my back. This guy was a big, tall Irishman. I don't know where he was from, Mr. McNally, and he used to encourage me. You know, he used to. We had a relationship. He says, you know, Mike, you know, if you apply yourself, boy, he says, you could be anything. You know, I see it, and I didn't get that. You know, I didn't understand that because I didn't hear enough of that positive stuff when I was young. And that's what I'm saying. It's the power, okay, that you have as the clinician, as the physician, as the social worker, whatever you do, okay, to change lives. Don't think it's a minimal thing that you know, has no validity. It does, okay, and I will leave you with that. Thank you. Honor.
Now, Mike. Okay, we have one more speaker who is Dr. Darlene Kitty. And Dr. Kitty is a Cree woman who is a family medicine physician. She practices family medicine in Chisasibi Hospital in the James Bay Territory, and is also really my counterpart at University of Ottawa. She is the director of the Indigenous program at the University of Ottawa Faculty of Medicine, working on recruiting students and supporting students in their program. I've known Darlene for many years. She is the past president of the Indigenous Physicians Association of Canada as well. Thanks for joining us, Darlene, and you may go ahead.
Thanks, Kent. Hope you guys are doing well. I'll say hello to Elaine too. I haven't seen you for a while since you were in your last year of medical school, I think. All right, so hello everyone. I got a bit of a hat hit because it's very windy up here in Chisasibi and stormy, so I had to really hang on to my tube. I guess I'll first start with you know, the positive and negative aspects of working in the community. I started up here in 2006, and I only spent part of my adolescence here. So I didn't really grow up here. It's my dad's community, and we were always visiting. And I spent summers here as a teenager. And I was down south for many years. My mom is from Waskaganish, so when I first started working up here, I worked mostly at Chisasibi Hospital, but I also did some locums in Waskaganish. And when you're starting practice, it's always a bit of a transition. So I really, you know, focused on my clinical work and helped out at, you know, both communities, mostly Chisasibi. So what I really enjoyed about working here is, you know, coming back to my culture. You know, I don't know Cree very well, and I'm still trying to learn it. But you know, other than that, I'm into, you know, fishing and hunting with my dad. You know, we have a cabin, so we go there sometimes. So it's really great to come back and you know, immerse myself in my culture, which I've been away for many years. One of the things I value is being a role model to our youth and you know, some of our post-secondary students. So I've been over the years guiding and talking with some of the Cree students, post-secondary students, but also some other First Nation students. And I think being a mentor is an important role that we should, do as we progress through the health professions. I'm also, I really value being a community leader. And I didn't realize that when I first started working because I was so busy with my clinical work and being on call and that. But over the years, you develop a certain expertise in the health issues of the community, and you're asked sometimes to give your opinion on something, for example, with the band council or with the school. So I really value being a community leader. And I agree with Mike said about relationships. Relationships are so important for you as a health professional to build not only your clinical relationship with your patients, the therapeutic relationship, but also with your colleagues, your peers, and people outside of the health organization wherever you're working. And sometimes you'll help them and sometimes they'll help you. So I'll come back to that in a little bit. I'm often asked to do a lot, and that could be a good thing. It could be a bad thing. The problem is it's often hard to say no, and I've been good at that a bit lately, but I still always find time for, to do something when I'm asked. I think over the years, I've gained a comfort in working in the community and understanding the challenges that our patients and families face. And I think people really appreciate that. One of the great things I've also value is becoming an advocate for our Cree patients and families. And after about 8 years of practice, this became very apparent to me because I was really seeing a lot of needs in the Cree Health Board. And I decided to step up and advocate with a more formal role as the president of the Council of Physicians, Dentists, and Pharmacists for our region. This council is you have to have a council for every health region. And I'm being the only Cree doctor in the Cree territory. Everyone else is Francophone or non-Cree, and I really stepped up then with the support of many colleagues to address the issues, and eventually became the clinical representative on the board of directors. So my role as an advocate really expanded after seeing so many challenges and facing situations where we're missing resources or missing workers to fill certain positions and help improve our health services. One of the biggest successes that we've had was advocating for mental health. We didn't have many employees in the health board who worked in the mental health department, and with all our physicians, we spoke up and went to the board meeting and decided to present this urgent need because our patients needed that. So it was really an important step for our council. And sure enough, over the years, the board of directors realized this. They want more for their communities and supported this need that we presented. And since then, there's much more mental health resources in the Cree communities. So this is an important step, one of other challenges that we face that at least we could speak up and address and get more resources. So it's one thing about being a health professional in the community, you have that opportunity to become an advocate, depending on your profession. So negative aspects of working in the community, well, like I said, it's hard to say no when you're asked to do things or give an opinion, but I always seem to manage to find time for that. One of the challenges I see is some of the non-Cree workers who are here in the health board, don't always see the positive aspects of working in the territory, like appreciating how culture is so important, our language, our traditions. And, you know, I've noticed that some nurses, for example, could be other health professions, but some people notice that they always seem to think, oh, the Crees are drunk, you know, the person's walking drunk down the street. You know, they think everyone is like that, when really it's a minority of people. So I take advantage of that attitude by teaching a person, when I can, to say like, hey, we're not all like that. You know, we're good people too. So, and it's like in society, there's a diversity of people across the community, across the region. So I value that opportunity to teach. Maybe another negative thing is, you know, we get asked a lot of medical questions, like in the grocery store when I'm buying groceries, I get asked, or they'll say, well, what do you think about this? You know, they have family issues and they might be starting to explain it to me, but I always tell them, well, you know, go to the hospital and see one of the doctors and we can help you. So I always kind of defer the problem so they can get good attention to it, but not in the middle of the grocery store. But, you know, I'm glad they asked me, because at least I can direct them, and they felt like they've been heard, you know, that I'm listening to them. So I think that's important too. I guess the only other negative thing I could think of was geography, because Chisasibi is like 1,500 kilometers from Montreal, and Val-d'Or is like 1,000 kilometers. So it's quite a ways away to go shopping at Walmart. But anyways, that's, I got a nice vehicle. I could at least drive and go get some stuff for Christmas. The other thing, I guess, you know, our Cree families often travel, so it's not such a negative thing. And we just have to appreciate timing wise, how long it takes to go down south and get stuff. Anyways, there's always online shopping. Okay, next question. Working in our own community, what's it like? Like I mentioned, my dad is from here. My mom is from Waskaganish, and you know, sometimes I'll see my cousins. I got many cousins. One time, one of my cousins was intoxicated, and I had to put stitches in. But it was a little bit awkward for me. But my cousin was very jovial, you know, so it seemed like a funny situation at the time, and it didn't take me long to put the sutures in. Sometimes, you know, one of my family members had been really sick and had to get medevaced, and I stay aside, like not as a physician, I'll stay as the cousin, you know. So I make sure those boundaries are there. Sometimes we hear of sensitive family situations that I'll kind of step aside if it's someone related to me, or someone that's like a family friend kind of thing, to try and stay out of the clinical realm and just focus on being a support. There's certain situations that have happened in the community that make things really sensitive. For example, suicide, a completed suicide. So sometimes it's important to be there for the family, or be visible when there's for example, a vigil, having lost someone. I'll go to the vigil usually. When there's community issues, like you know, like some social meeting that when something needs to be discussed. Unfortunately, last summer we had 4 or 5 completed suicides, and so I went to the community meeting to support those who were there, but also wear my physician hat, you know, and brainstorm on what we can do to address the situation positively and provide more supports in the community. So, things like that, we really have to sometimes set boundaries, but sometimes you have to step up and put your health professional hat on. I'll just back to when my family members in Emerge, for example, it won't be me taking care of that person. I'll ask one of my colleagues to take care of the patient, and they readily help me, when they recognize that many of my family members are here in the community. Financial aspects, well, working here up in Northern Quebec is, it's a good income. One of the things I always try to do is to support community and cultural activities. For example, when our powwow happens every August, or when our annual gathering happens every July, I'm always there to, support the community, buying crafts and things like that, buying food. I'm also supporting other things like the youth center, when or for example, hiring a youth to shovel my driveway, so I'm always trying to support the community, going to the restaurants, etc. Dealing with limited resources. Well, in Chisasibi, we have the regional hospital, 29 beds, but we don't have a CAT scan, an MRI, or a surgeon on call. We have to do all our care with the clinical focus, like using history and physical exam to determine the best diagnosis, and then make phone calls to talk with specialists if we need to, and send a patient out if we need to. So having worked up here initially, it really gives you a good opportunity to hone those skills. We also collaborate with like our own colleagues when we're deciding on a case, what to do, but also in talking with the specialists down south. And so sometimes we're medevacing the patient, and sometimes you're the physician going on the plane, but to accompany the patient. So it can be very challenging. But usually we do the best we can, and it works out fairly well, and sometimes not so well if the patient's not doing well and gets more sick, or down south. We're collaborating with our referral centers in like Val-d'Or, Amos, Chibougamau, Montreal. So, we value those connections. That's our corridors of care. So, and sometimes there's challenges with these referral centers, because they don't realize the reality of what it's really like up in Chisasibi. And I know Kent understands this well, because he used to come to our community for many years. It's now become a main issue because of the death of Joyce Echaquan and racism, the racism issue, plus the cultural safety, is so important. We're lucky that our physicians, dentists, and pharmacists are learning about cultural safety for at least 5 years now, and the nurses are learning too. So at least we can give culturally safe care, at least most of the time, to support our patients. Boundaries. Can't read my own writing. Oh yeah. Like I mentioned before, when patients come to me in a grocery store, out in the community somewhere, they're asking me questions, I always refer them to the hospital or the outpatient clinic, or they can make an appointment with me. It's at least they have that opportunity to ask me, get it off their chest, but then they know there's somewhere that they can go to discuss it further. One time someone came to the door of my house when I first started working up here, and they were asking me a mental health question. And I said, oh yeah, well, if you make an appointment at the hospital, you can see me. Just tell them I said okay, and I can I can see you, and they'll book you with me. So that's the only time someone ever came to my house. But I think people in the community really realize you work hard and they respect your time off of work. Living in the community versus traveling to the community. Well, I had been down south for many years, as I mentioned. And when I came to work here, I was welcomed to the community. I felt part of the community eventually, because I was working so hard at the very beginning, lots of on-call shifts and stuff. But as I settled in, when people see me out at the grocery store or at the arena or at the gym, they were glad to see a Cree doctor. And in attending our summer activities, there's usually busy in Chisasibi, lots of things going on. I took pictures, and we also have medical trainees up here, so I took some medical students and a resident out in a freighter canoe for a boat ride, and my cousin and her partner were taking us in their boat. So I took a nice picture of it, and years later, the public health department asked me to use the picture as part of one of their public health reports. So I did, and it's a nice picture to show how I'm taking part in my own traditions, but also the students and residents are learning about Cree culture and traditions. So that was nice. I think, the Crees are very mobile and sociable people. So people come and go from Chisasibi all the time. So it's not so much, they see me leaving for meetings and conferences and things like that. I also have a house in near Rouyn-Noranda. I go to that house sometimes, and it's I'm just as mobile as everyone else, so it's not necessarily a bad thing. I think people really miss seeing me sometimes, doing work. With COVID, it's changed the way our physicians work up here, and right now I don't do emerge. I'm doing home care, and also taking care of the elders that are little, I'll call it an elders home. So we're trying to limit exposure of physicians to and other workers for the elders. So that's why I'm focusing on those two groups. And it's a pleasure to take care of my elders. So anyways, with COVID, I end up staying longer in the community because of the risk. We didn't want to go down south, and my parents are with me up here, so that was nice. One of the things I learned about living in the community is it's good to be visible, be out there, sometimes going to a band council, like a local general assembly, being part of the community gatherings, also being not only visible, but being audible too, because I go to the radio station and give little radio health shows once in a while. Most recently, I did one on the flu and COVID. So it's important to be heard as well. And so people, I think, really find that, I've been well integrated in the community over the years. And even though I come and go, that's okay too. They know I'm a busy person, and I also work part-time in Ottawa, but I do also many other things. So I think they're glad to know that I'm, doing this, wearing all these different hats, and ultimately to improve, the Indigenous health, not only for the Crees, but others as well. So I think I'll stop there. Thanks.
Thank you very much, Darlene. Thank you to all our speakers for sharing some of your knowledge. We have a little bit of time for questions. I don't see any right now in the chat, but maybe I'll start off and just prompt a few questions. So question, I guess for everyone, but it might be geared a little bit more towards Darlene. But Dr. Kilabuk or Michael, please feel free to weigh in as well. How resources, so we talked a little bit about resources, things like that, but how do you deal with limited resources for, like, say, for rehabilitation, you know, for whether it's occupational therapy, physical therapy, speech and language therapy, the professionals themselves, or, you know, the material and equipment that is needed? How have you dealt with some of those things?
So if I can start, yeah, if I can start, at least in Chisasibi, when we know that a patient is needing certain services and resources, like, for example, coming out after a hospitalization in Amos, where orthopedics service is provided, for example, a hip fracture in an elderly person, we work with the Amos hospital staff to decide, okay, what does this patient need? Physiotherapy for sure, perhaps occupational therapy, and certain medical equipment like a walker. There is collaboration between our nurses and their nurses to get a handle on what care is needed for that patient. And at the same time, the physiotherapist over there consults with our physio over here to say, oh, this person is doing fairly well or needs a little help with this. And so they collaborate, and then also, if needed, occupational therapy. So there's always a discussion. Unfortunately, sometimes it happens so fast that sometimes they really need the bed for someone, and they end up having to send the person sooner than when all these things are already arranged from our end. So, you know, that's happened once in a while, and we're not that happy about it, but then we end up having to make do once they get here. So, you know, it's usually a collaborative effort, but sometimes it doesn't always happen that way.
Elaine, anything to add?
I think, I mean, something very similar in terms of, say, like for physiotherapy, or even say like wound care, or anything that I've had in my experience. So we do have a physiotherapy program, which is nice, and then mental health within, so Iqaluit, and then in the communities as well. And then home care, and a lot of it's just, like you're saying, kind of a collaborative discussion with each of them, particularly actually with every consult that I put into any specialty service. I usually give them a call, or they come by my office, so we can have a discussion about what, you know, what is the question, what do they need to be followed for, or what I'm worried for, and if services can't be provided, then it's a discussion about what can we do, and trying to explore all those options of what can be provided based on kind of the services that we do have. I think, and then other things I can think of, even for, you know, if services aren't necessarily provided. So say, you know, a patient, they don't offer bariatric surgery in Iqaluit, so, but they're interested in a weight loss program. So trying to, you know, at least trying to find some resources to help patients, even if that specific service is not provided.
Great, thank you.
If I can add, Kent?
Go ahead, Darlene.
Just one thing that's helped us quite a bit in the past few years is telehealth. So sometimes we're using telehealth to talk with a specialist or a wound care nurse, for example. It really has helped us address certain cases when a patient, for example, can't travel to the south. And I think there's a bigger role for this as time goes on. We're going to be using it more. But even now, we're using Zoom meetings, you know, between a psychiatrist and their patient in a secure environment. So technology is going to help us more.
Great. Thank you, Darlene. I have one more question, and then anyone else feel free to ask a question as well. Directed a little bit more at Mike. Mike, Darlene shared a bit of her experience of living in the community and providing services in the community. And I just wondered if what your experience had been living in Kahnawake when you were working there.
Could you be a little bit more specific?
Yeah, basically, how did you were working in youth protection in Kahnawake for a while from the community. Just what was kind of your general experience with that? Did you have people stopping you in the street? Did anybody come into your home, or was it mostly a positive experience?
I would say it was. I don't know if positive would be the word to describe it, because social workers are kind of like social policemen, right? We kind of like have to lay down the law to some degree after somebody's been charged, or there's been allegations that a person has done something wrong, abused their kids, or whatever. And so I kind of like didn't get disrespected ever, but people, you wear. It's kind of like you wear this occupation on you. I'm retired. I haven't been a youth protection worker since 1998, and it's people I think still think of me as being in that role. I can't get out of that role, the heavy, and it's I found it a little bit it's a little bit disconcerting for sure. I've learned to accept it, but when you live in what can you really expect when you're living in small communities, like the way we do? I mean, everybody knows everybody, and everybody has has some kind of an idea what people do. So I kind of just like looked at it that way. I'm always available. People, like with Dr. Kitty, people would show up my house. Mike, I got to talk to you. And I would always reflect them, or refer them back to the appropriate resources. And I've had people from all walks of life over the years, believe me, from I really can't say, but people from the so-called higher end of our community to people who remind me of my past, poverty-stricken people. I've had that whole range of people put their trust in me when things are down. They always kind of had that feeling they could turn to me and ask me, what do I think it is? What should I do? And I never turned them away. It's just the way I did my thing. I mean, it's it goes beyond being a social worker. I'm like I felt like I was like a resources. The community put their trust in me to a degree with having some knowledge, and it's my job, whether I'm retired or not, to share what I know. And that's the old Indian way. That's what I call it. I just do it like that, and that's that. If I don't have the knowledge, I mean, I'm the first one to refer you. But if I have something to help, I will give it away. And that's the way I did things. Mm-hmm.
Great.
Yeah.
Thanks, Mike. Well, our time is just about up. Does anyone have any last question?
I do have a question if you have time.
Go ahead.
This could be to anyone, but I was wondering like how you approach situations with coworkers, maybe whether they're Indigenous or not, and maybe you feel like they're missing some cultural competency or missing some information, and like how you approach maybe informing them or referring them to someone else to talk to.
Any
In social
takers?
work, we say one thing: you start where the problem is. You start where the person is. Okay, and I guess what that really means is you deal with that feeling. If you're thinking somebody is going to need, you know, some knowledge, they're going to need to be. It's just like if you're somebody, let's say from the non-native world, is just assuming too much, you know, or just tripping over some things that, you know, they just simply don't, they're not aware of because of, you know, not dealing with Native people in their lives. You start off where that's where the work is. That's where the issue is. You start where the work is, you know, and you put that out to that person in a gentle way, and especially if you have some, you're aware of some resources, you know, and that's all you can do. That's professional behavior, you know, to just gently put that information out there to try to steer them in the right direction when you hear something that doesn't measure up, or, you know, that type of thing.
Anyone else? Anything to add? Darlene?
Yeah, I echo that. You know, basically, when I see like a healthcare worker has not recognized something with an Indigenous patient, or for example, a Cree patient, that they may not know, say, that person was a residential school survivor, I might take that health professional aside and say, hey, just want to let you know, you know, this person is a survivor, and you should learn a bit more, and maybe do a brief explanation over a couple minutes of what it was, so at least they understand where that patient is coming from. I always try to teach people when I can, you know, to address the situation.
Yeah.
Yes,
Great.
I echo definitely what Mike and Darlene had said about obviously pointing something out, like bringing them aside to point out, obviously not in front of other people, and obviously kind of saying in a very respectful way, in terms of, you know, how that couldn't say it was culturally insensitive, and like you said, kind of provide an explanation. And if you know, aren't giving them resources for more information, if you know, you don't have that much time or things like that, but yeah, definitely do it kind of privately and providing them the education about why it was culturally insensitive.
Great, thank you, everyone. The only thing I'll add to that is a lot of it depends where you are in your career as well, because sometimes it's very hard as a student or you know, a young professional just starting out, and someone, you know, quite often the scenario is it's an older person or maybe someone more senior than you, and it can be a little difficult to do that, and that has to be understood as well. But trying to find your strength to do that and talk to them in a respectful manner and private manner as best you can is always a good idea.
The old word for that is a well-known phrase of saving face. You know, you never in any society, I think confront anybody, you know, in a group of others, and you always respect the person, pull them on the side, and ask them, or, you know, gently let them know what's on your mind, something that you saw, something that triggered, okay, your reaction. And that's where you start. That's the old social work way. You know, you spot something and you just gently pull that person on the side and you try to talk about it. Maybe it's nothing, maybe it's something, okay? That's the way you have to do it, but you definitely pull the person on the side everything is about saving face, you know, not because we're a social society, Native people on the reserve. We live in small communities, and everything is about, and Dr. Saylor knows this, everything, you know, you rise and fall with your reputation. You could spend your whole life building your reputation and, you know, really impact it in a second or two, you know? So you got to understand that as Canadians, you know, those who are not Native, that we're, you know, we're under pressure. I think we gotta, those people on the reserves, professional people, are under pressure. Okay, we have to. We're always under the gun. It's like being a little bit of a movie star or whatever, because people will always look at you different. They will always look at you and they will expect you to be perfect. They will expect you to always say the right thing, to do the right thing. That's going to be like the way it is and for the rest of your life. And that adds a pressure, you know, on us. So, you know, you have to be, you know, aware of that. And yeah, so I think I'll just leave that at that. I hope I was clear anyway.
Very clear. Thanks, Mike. Well, our time is up, so I just wanted to thank everyone for joining us, and a special thanks to all of our speakers, Dr. Elaine Kilabuk, Dr. Darlene Kitty, and Michael Loft for joining us today. We really appreciate it. Please look, keep your eyes open. We hope to do more student workshops in the future, probably in the winter, and we may be actually, Laura, we may actually be discussing a little bit more of that question that you raised on our next workshop. So thanks everyone for joining us. I'll ask Calvin to help us close the meeting.